Welcome to the introduction of the MiniMed 670G system with SmartGuard technology. I'm Fran Kaufman. I'm a pediatric endocrinologist and also the Chief Medical Officer at Medtronic Diabetes, and it's really my pleasure to be here with you today to talk about the MiniMed 670G system. So let me start with this important information, safety information that you can access online. There's a black box warning about the total daily dose as well as the age, and of course this is indicated for people with type 1 diabetes for 14 years of age and older. This device should not be used in anyone under the age of 7 years old. This device should also not be used in patients who require less than a total daily insulin dose of 8 units per day, because the device requires a minimum of 8 units per day to operate safely. Here's a picture of our MiniMed 670G system, the world's first hybrid closed loop. I hope you can appreciate it. It's our new pump platform, and that shield in the center, that blue shield, indicates that somebody's in closed loop, and we think that that will help them know whether they are in closed loop or what we're calling auto mode, or in open loop or what we're calling manual mode. So the components of the system, again, are our new pump platform, our SmartGuard hybrid closed loop algorithm, which is embedded in the pump itself, our Guardian Sensor 3, which is a new sensor, 2 generations from where we are now in the United States, and of course it has a specific Guardian Link 3 transmitter. The system is used with the Contour Next Link 2.4 blood glucose meter to calibrate the sensor, and also very excited about new CareLink reports that will focus in on hybrid closed loop functionality and make it easy for you and your patients to understand what this is able to do for their glucose values. This slide, I'm showing you some of the other functionality inside the MiniMed 670G system. So there is the option to have suspend on low, so insulin suspension at a preset threshold. There's also suspend before low. So rather than you wait till they get to that threshold, you suspend 30 minutes in advance. And also, both of these inside the MiniMed 670G system are able to resume pre-programmed basal insulin when the sensor glucose values recover. Now when we get to auto mode, now we're talking not just again about suspending insulin, but now giving basal insulin through the algorithm as a 5-minute insulin delivery mechanism, and we think that this will help really markedly advance the field of type 1 diabetes therapy, as well as we have great evidence that shows that we're able to improve the time that the patients spend in the target range. So this schematic shows how both the auto mode basal delivery goes as well as bolus. So on the left side, above you can see the sensor glucose tracing, and below you see the delivery of insulin. So as the sensor glucose drops, so does the insulin delivery. It can get to be 0, and then as sensor glucose fluctuates, so does the delivery of insulin. On the right side, you see what happens when the patient takes a bolus, and again, they're responsible for their meal boluses, determine how much carbohydrate they're going to eat, put it into the bolus wizard where you have pre-programmed their carbohydrate to insulin ratios. They take that bolus hopefully before they start eating, and then if they overestimate or underestimate, the auto mode feature can adjust around them. So this is an actual tracing from a patient, 4 nights from a single week of an individual patient. At the top is the sensor glucose value. The line running across is the target of 120 for the algorithm. Below is the insulin delivery, and I think you can see how dynamic that insulin delivery is. The blue line running through it would be the preset basal rates if somebody was in auto mode. And I think you can see from night to night the sensor glucose is tightly controlled, and at the expense of great variability of the delivery of basal insulin through the algorithm, and certainly much more variable than you would see with the preset basal rates from manual mode. So I do want to tell you a little bit about the Guardian Sensor 3. Again, it is a new sensor for us, 2 generations from where we are now in the US. And as expected, we've done quite a significant analysis in a pivotal trial to look at the accuracy of the sensor. And so that's determined by what we call the MARD, the mean absolute relative difference. So simultaneously, venous blood is extracted through a reference value, and we compare it to the sensor data at the same time. So with 3 to 4 calibrations of the sensor a day, the MARD is 9.6, and with 2 calibrations, the minimal number of calibrations that can be done, it's 10.5. In addition, there's a specialized chip inside the transmitter that's looking for outliers of the sensor, and if it determines that the sensor may be drifting, it will trigger another calibration. If it can resolve the issue with the sensor, it will continue to run closed loop, and if not, we will not run closed loop on a sensor that does not have optimal performance. The sensor has a longer life, up to 7 days, and is used with the one-press inserter. So now, let me go over the pivotal trial of our hybrid closed loop system that enabled us to get FDA approval for us to be able to commercialize this in the United States. So we had a great relationship with the FDA. We met with them frequently. We showed them lots of our feasibility data, and that enabled us to do our pivotal study in patients with type 1 diabetes, greater than 2 years duration, A1C 10% or less, and all the patients were on pumps for greater than 6 months, plus or minus CGM. We had both an adolescent cohort, 30 subjects, as well as an adult cohort, 94 subjects. I think you can see on the graph that this is a typical type 1 population, long duration of diabetes, total daily dose as expected, and then a mean A1C for the adolescents of 7.7% and for the adults of 7.3%. So overall, a relatively well-controlled cohort. And then the schematic at the bottom shows that we had a 2-week run-in period, some educational time, and then the patients entered auto mode or closed loop, and that was for a 3-month duration. So first, let's talk about the A1C result. So there was a significant change in A1C with a decrease of 0.5%. So baseline was 7.4, and at study end 6.9. Hard to find too many type 1 trials that have the mean A1C below the ADA target of 7%. So if we look at that at baseline, there were about 38% of the patients with an A1C 7 or less, and at the end of the study, 62% of the patients achieved that target A1C value. A general shift to the left for the entire A1C distribution between run-in and study phase. This slide, I think, is very important to show really the functioning of the system. So it shows for the entire study period compared to the run-in period, which is in gray, the study period is in pink, the overlay of all the sensor glucose data. And it goes from x-axis from midnight to midnight, and the black line is the median. I think you can appreciate that there is a tightening of glycemic variability across all the patients as well as the 2 cohorts by age. At the beginning of the graph, you see slightly higher sensor glucose data that gradually is brought down through the nighttime period. Then you see the breakfast, lunch, and dinner meal slight peaks that we would expect to see in anyone who's eating. Very predominantly in the adults, and in the adolescents you see breakfast, lunch, dinner, and then pretty much nonstop eating. As a result, in the adults, we see mainly a mitigation of lows, and in the adolescents, we see mainly a mitigation of highs. And during the nighttime period, where auto mode is actually doing it all on its own outside of bolus insulin delivery for the most part, we see a mitigation of both high and low. And at the bottom, I hope you can appreciate that there was a tremendous amount of time people were in auto mode, 87% of the time, and as expected, more in the adult than in the adolescent cohort. So if we take all that data and we put it in tabular form and we look at run-in compared to study phase and just look at the high values, the low values, and the time and target, I think you can see that both the high values and the low values are decreased during the study phase as a result of being in auto mode, and more importantly, the time in target is also increased to 72% for the study period. During the study, which was over 12,000 patient days of exposure to the device, there were no severe adverse events, specifically no severe hypoglycemia and no diabetic ketoacidosis. So if we look at our overall strategy, where we've been in our journey in improving the outcomes of people with type 1 diabetes, we started with our sensor augmented pump as a platform upon which we could build automation of insulin delivery. All along the way, we have also been committed to building the evidence with our own studies, as well as supporting numerous investigator-initiated studies as well. Then we look at suspend on low, and we see that there is a mitigation of low values as a result of this technology. Then we can go to suspend before low. Again, now in anticipation of hitting a preset threshold, insulin delivery is stopped 30 minutes in advance. Again, studies to show that not only are we decreasing the amount of low, but we're actually preventing hitting that threshold to begin with. But now the big leap, the most important in the automation of insulin delivery with our MiniMed 670G system auto mode feature, is that now we have data to show a change in A1C, an increase in the amount of time in target, decreasing glycemic variability. We're in the midst of doing a pivotal trial in the pediatric population. We have a large global trial that we're getting ready to begin as well, and we're committed to not only working with our MiniMed 670G system, with all of you supporting you how we can, but also continuing to advance for future iterations and improvements in outcomes for people with type 1 diabetes. So in closing, again, thank you for your attention today. I hope you learned about the MiniMed 670G system. I hope you're excited, and we look forward to working with you to enable you to help get your patients on the device so we can transform diabetes care together.